I'm Byron Joyner, Associate Dean for Graduate Medical Education, and it's an honor for me to be here and to co-host with Dr. Brian Ross from Anesthesia. Medicine is becoming more of a team sport. We are actually having to work in interprofessional and interdisciplinary teams, and I'm thinking that you're going to see that tonight with the two guests that we have. Tonight, Drs. Jeanne Poole and April Stempien-Otero will demonstrate the teamwork in cardiology. And their presentation, which is entitled When Your Heart Needs to Help, Cardiac Interventions and Repair, will demonstrate this with some surprise that they have for us. Jeanne Poole is the professor of medicine in the Division of Cardiology, and she's also director of the Arrhythmia Service and Electrophysiology at the University of Washington Medical Center. Dr. Poole sees patients with a broad spectrum of heart rhythm abnormalities and symptoms. She surgically implants pacemakers and heart defibrillators and implantable cardioverter defibrillators, and has been involved in some of the nation's largest and most comprehensive studies of ICDs used to prevent sudden death in patients. She directs the Clinical Cardiac Electrophysiology Program, training advanced fellows in the field of electrophysiology and cardiac arrhythmias. Dr. Poole earned her medical degree and performed her residency and cardiology fellowship here at the University of Washington School of Medicine. She did her internship at the University of Minnesota, Twin Cities. She enjoys spending time with her family. Here she is skiing in Breckenridge, Colorado with her son and two daughters. Our second speaker tonight is April Stempien-Otero. She is an associate professor of medicine in the Division of Cardiology. She is the Craig and Julie Tall Endowed Professor for Heart Failure Research. She's also an attending physician here at the University of Washington Medical Center, where she cares for patients with end-stage heart failure before and after cardiac transplantation. Her research, in conjunction with the University of Washington Institute for Stem Cell and Regenerative Medicine, is focused on the role of bone marrow-derived cells in cardiac repair and regeneration. She earned her medical degree from the University of Connecticut School of Medicine in Farmington, Connecticut. Dr. Stempien-Otero did her internship and residency at the University of Virginia in Charlottesville, where she was chief resident. She completed a cardiology fellowship at the University of Washington and joined the faculty here in 1997. She received an outstanding CME Teacher Award from the University of Washington School of Medicine and has been named among the best doctors in America since 2002. A strong advocate for women's cardiovascular health, Dr. Stempien-Otero founded the local Women in Heart Disease Initiative for the American Heart Association. Dr. Stempien-Otero and her friend Sherry are working moms who believe that real food is the real prescription for healthy and happy lives. Knowing how challenging it is to prepare meals when you're busy, they've developed a blog, crunchtimefood.com, where they share ideas about making real food fast. The schedule tonight is going to be somewhat of a tag team approach. First, Dr. Stempien-Otero will briefly discuss the issues of heart failure. Then Dr. Poole will make a presentation on implantable devices. Then we're going to have a surprise guest, one of their patients, which will be very interesting, I'm sure.
So we're going to go back to our patient who initially did well and felt better with the BIV ICD, but continued to have soon after developing symptoms. So what are the options now once we have exhausted our medical and electrical therapies for heart failure? Well, our number one option that everyone thinks of right away is heart transplant. And heart transplant is a great option for a group of patients. Heart transplants have been performed in this country starting in the early 80s at Stanford. And you can see here that, where's my little thing? You can see from 1981 to 1990, there was a dramatic increase in the number of transplants, both in the United States and worldwide, the green here being North America. But interestingly, from 1990 until the present day, the number of transplants has remained unchanged at about 2,200 a year in the United States. And that's because of organ availability. We've not been able to increase the number of organs available for patients with a transplant. So we continue to be constrained of having young patients who are good candidates for transplant, but not being able to find hearts for them. Because of this, in the 90s, many patients would die on the transplant list waiting for an appropriate organ. Because of that, what was developed by bioengineers was something called the left ventricular assist device. They started saying, is there a way we can keep people alive and healthy until they have a heart transplant, until the right donor becomes available for them? And the first generations of left ventricular assist devices were actually quite cumbersome. They were developed as a bridge to transplant for patients that were too ill to survive. The console that ran them was actually as big as this podium and on wheels. And we'd have people like pushing this thing down the hallways in the hospital. They couldn't go home on them. They literally had tubes coming out of them to a console. But those devices actually taught us a lot about what works. So what is a left ventricular assist device? Well, a left ventricular assist device is not an artificial heart. An artificial heart would completely replace the heart. A left ventricular assist device, as you can see here, sucks blood from the left ventricle into a pump, and then that pump pumps the blood into the aorta. So instead of blood coming into the normal left ventricle and being squeezed out into the aorta, it bypasses the pump, which doesn't work, and you have a secondary pump here taking over. As we got better at this, the later devices could be run on battery packs so that patients could go home. And you can see here that the electrical wire that runs the pump actually comes out of the skin, is attached to a controller which runs the pump and then can be attached to battery packs so the patient can walk around and actually leave the hospital. Here's how one of them works. This is our first generation. The blood comes into the pump from the left ventricle. It pushes the pusher plate down. Then the pusher plate ejects the blood out into the aorta. These first generation of battery pack pumps really worked a lot like your own heart does in a pulsatile manner. Needless to say, these pumps were wildly successful. I cannot even convey to you how, in 2000, we had patients who previously would have died, who we put the pumps in, who successfully got transplanted. And not only did they survive, but they thrived because they could go home and exercise. They weren't stuck in a bed in the hospital getting weaker and weaker and weaker and weaker as they waited for a transplant. And actually, our transplant survivals got better with the pumps, and everyone saw this nationally. Twice as many patients were surviving to be able to be transplanted, and they had better functional capacity. But, as I mentioned, we can only do so many transplants a year. So people began to ask, after this success with the pumps, maybe the pumps themselves could be the answer to the limited number of donors for transplant. And thus, the first trial was instituted. Instead of taking an LVAD and using it as a bridge to transplant, or using it for short term after cardiac surgery, which was also being done, the concept of destination therapy was brought up, of the LVAD as a destination. So the first trial to look at this was called the rematch trial. It was a trial of destination LVAD versus medical therapy for patients that had end-stage heart disease who were not candidates for a heart transplant. And as opposed to Dr. Poole's trials, this is a very small trial because it was very specialized centers that could put in these devices, and we were actually a center for the rematch trial. 68 patients got the Heartmate 1 LVAD, and 61 had medical therapy instead. And here's the Kaplan-Meier survival curve, quite a bit more dramatic. You can see here in patients with end-stage heart failure that the medical therapy arm, everybody was dead by 2 years. So this is a sick group of patients that would not survive without therapy. Whereas the patients who were randomized to the left ventricular assist device at 2 years, although their survival was only 25%, that was still significantly better than anything we had ever seen before. What came out of this trial was that the limiting factor in these left ventricular assist device patients in the first generation was that most of the deaths were from infection. As I showed you, there was an actual line, electrical line coming out of the patients, and that caused infection in the patients. But the survival benefit was so great in this trial that the FDA approved the device for destination therapy in addition to bridge to cardiac transplantation, and Medicare approved payment for the Heartmate as destination therapy. The infection issue, though, became problematic, and that particular device had actual artificial heart valves that would then become infected, and patients would either die from infection or have to get a new device put in. So the engineers went back to the drawing board. They noted that one of the problems with the device was with the pulsatile nature, it actually moved in the body, and that rocking was irritating and potentially causing an infection. And so they developed what they call the continuous flow VAD. This had less rocking, it was quite a bit quieter, the other ones would keep some patients up at night, and it had no valves. The minuses of this device was that it required anticoagulation or blood thinners because it worked a different way than your normal heart. The normal pumping motion of the first generation actually did not require anticoagulation. And it was continuous, there was no pulsation. And I have to say that I met with some engineers regarding this device, and I thought they were freaking bonkers because I said, every single being on the earth has a pulsatile heart. If you go to the zebrafish, if you practically go to ants, almost everything has a pulsatile heart. And that if we take that away, what's going to happen? And they said, well, the cows we've put them in are doing great. I said, okay, I'm going to trust you on this one. And it was a good thing we did because then came the Heartmate 2, or a continuous flow left ventricular assist device. So not only was this continuous flow, but it was also quite a bit smaller. And what happens with this device is that blood is continuously sucked into the device, and this flow little rotor turns at 8,000 RPMs, continuously sucking blood from the left ventricle into the aorta constantly. So no beats, just constant circulation of blood. So we asked ourselves, we think this is going to be better for patients than the Heartmate ones. The first initial indication was this bridge to transplant, so we started to gain experience with bridge to transplant, and indeed the patients seemed to be doing better. But again, if we wanted to have an alternative to transplant, what could we do? So this trial was set up, which was a Heartmate 2 versus Heartmate 1. And in this trial, it was actually enrolled in a 2-to-1 because we all liked the Heartmate 2 so much better. It was hard to go and tell a patient that they could have a Heartmate 1 instead. But we couldn't give them a Heartmate 2 as destination therapy because it wasn't approved except by going through the trial. So this way, they had twice the chance of getting what we thought was the superior device. And the trial indicated that if they got a Heartmate 1 and they had problems, we could change it out to a Heartmate 2. So this was, again, a very ill group of patients. 77% were on continuous IVs in the hospital to keep their hearts pumping, and 22% were actually on temporary pumps in the hospital. And the age range, you can see, average age of 62, but the range from 29 to 79. And actually, in one arm, there was an 80-year-old. And this indicates the group of patients that were not candidates for heart transplant because of age, but were very healthy people otherwise that we felt would benefit from destination therapy. So this study was actually just published last year, and you can see here that as we predicted, the patients who had the continuous flow VAD did excellent comparison to the pulsatile. So identical, we basically repeated the rematch trial with these. 25% were alive at 2 years, whereas over 50%, almost 70% of patients with the continuous flow VAD were alive at 2 years. So a dramatic improvement with the device. And again, as you recall, the medical therapy for this condition is universally fatal at 2 years. So somebody asked me, and yes, this is what Dick Cheney has right now. So in summary, we now have these continuous flow LVADs who, in patients with heart failure, significantly improve survival, have decreased device failure at 2 years, and both devices significantly increased both length of life, but also in other secondary studies, improve their quality of life, and their functional capacity. So they weren't just tethered to something. Their quality of life was improved comparison to medical therapy or the other device. They could do more. They could live nearly normal lives. And that's why the Heartmate 2 is now approved by the FDA and Medicare as destination therapy. So who do we propose this for? It's obviously a big thing to be implanted with a device. Patients who have isolated left ventricular failure. As I showed in the picture, the device only bypasses the left ventricle, and you need to be able to get blood over to the left ventricle through the lungs. If your right ventricle is not working and you can't get blood across to the left ventricle, you're not a candidate. Patients who have adequate lung and kidney function to withstand regular bypass surgery. So if somebody has such bad lung function or kidney function that regular coronary bypass heart surgery would be high risk for them, they're not a candidate for this device. They have to have no other illnesses that would increase their 3-year mortality. So for heart transplant, because of the limitations in the donors, we require patients to have essentially 100% 5 to 10-year mortality. So patients who've had cancer, for example, have to be completely clear for 5 years before, and 10 years in some cancers, before we will transplant them. Whereas with the LVAD, because we're looking at a shorter term, especially for older patients, we have shrunk this down a little bit. No active infections. This is critical. We still continue to have problems with infections with the LVADs, and for patients who are listed for transplant with an LVAD, if they get an infection, it moves them to the top of the list. So patients who are going to have this LVAD for the rest of their life have to be meticulous about not having infections going in and meticulous in caring for the device in the exit site so that they don't develop any infections in it. And then most importantly, and this is actually the sticker for most people, is you have to have as good social support, if not better social support than we require for heart transplant. You need 24/7 coverage for the first 3 to 6 months after LVAD. And that is because you learn how to change the batteries, how to unhook. You need somebody there with them. We have lost a patient or two who was by themselves and fumbled and dropped a battery and the device stopped and they weren't found in a time. So it really requires extensive family support and friend support to be able to have a device like this. I don't know who Dick Cheney's 24/7 is. So I'm going to show you a video of an LVAD going in. And this was provided me by Dr. Nahush Mokadam, who's our primary LVAD and transplant surgeon here. So he has to do the Nahush Mokadam thing. And he has taken a 5-hour surgery into 2 minutes. So here they are making the pocket, opening up the chest, again, similar to what Jeanne was talking about with the pocket, except you have a slightly bigger pocket for your LVAD than for your defibrillator, and it's down in your abdomen instead of up in your chest. Here they're putting a hole in the aorta so they can put the patient on bypass during the procedure. There's a hole in the atrium. Now they fit the device, they make sure that the pouch fits, that's just a plastic. Now they core out the left ventricle. Yes? That's where the device is going to fit. They have to take out that piece of tissue to put the device in. So they cut out that little core, which makes me happy because I use that for research. So I'm down there like, hurry up with the core. Make a nice hole, make sure it's a good size, and then they put this sewing ring in around the core so that they can put the device into this area. So here's the sewing ring all the way around. Now this is the part that goes into the left ventricle right there, the sewing cuff. Nice and neat sewing. And then they look in, they bring blood up so that they get rid of bubbles. And then, just like that, they screw in the LVAD. Tie it down. If you don't tie it down, it wiggles loose. It was unfortunate finding that out. Now, this is where they're taking the wire, the electrical wire, and pulling it through the skin right there. And now they're putting in the graft into the aorta here. sewing the aorta outflow graft. There it is, Gore-Tex graft into the aorta. And now they're screwing in the other side. So there's the graft going down and the device, and then they're closing everything up. So that's it, 2 minutes. Takes 4 hours. So I want to talk to our patient again, because our patient got more ill and was listed for transplant, but is expecting a long wait for transplant and wanted to get out of the hospital to his lovely friends in Everett. So we put in a Heartmate 2 device. So Rodney, will you come up? So when you had your device placed, when?
It will be 3 years next month.
3 years.
3 years.
And so here's his controller right here, as I mentioned. The controller has, and there's one up on the table here for you to look at. It has a little alarm, which goes in yellow. There's the dreaded red broken heart, which means call us stat. But what's it been like?
Fantastic. It has brought up my energy level an amazing amount. My girlfriend, after I got it done, she noticed that I actually had pink skin and I was not gray after all. So that was good. It's allowed me to basically return to a normal life. Landscaping, out doing walks on the weekend and such, so that I can live again. It's not just a tie-in to, the house.
And how frequently do you come down here for follow-up visits?
At the beginning, it's once a week, and now I come in at once a month. Come in, they do checks, blood work, and check to make sure the site's fine, and check to make sure the device is still working properly.
And anything, and you're taking care of your mom. I mean,
Yes.
The other thing is now you, with your heart failure, with your device, now you help me and helping take care of your mom with her heart failure.
Yeah, I've got some comments when I've been down here, and I'll be pushing my mother in a wheelchair, and they'll say, "Wait a minute, you're the sick one." No, I got to do this.
So any things with the device irritate you? Can you hear that high-pitched hum that I listen to when I listen to your lungs?
I can, yes.
I wonder if we can, I wanted to see, no, it's down here, can we, there it is. Hear that? That's his device. 8,000 RPMs, right there.
9,100.
Oh, 9,100, I'm sorry, he said it 9,100.
And I need to know that. I do hear the device. My girlfriend will point out to me some evenings, she'll say, "Boy, you're whistling loud tonight." Usually when things are quiet, I'll notice it more than if there's ambient noise. Like right now, I do not hear it. At first, it was worse, I think. I've kind of gotten used to the sound, so it really doesn't bother me. From what I've heard with the first generation of devices, they were quite a bit louder, as well as they would get the clicking sound, and I have none of that, so it's not bad.
So able to do everything you do. And 3 years in, no complications.
No complications
Doing
whatsoever.
great.
You can't go swimming, can't take baths. When you do shower, it actually goes into a shower bag so that it does not get wet. Other than that, now, when I first came out of the hospital, I had a halter vest, and I've learned that it's just as easy just to be carrying my batteries actually in my pockets. So as I walk around, nobody can say, "Oh, look at that," People do occasionally ask from time to time and are kind of fascinated by it. And, that doesn't bother me. If the more I can help spread the word of what's going on, that's all the better.
And you haven't run out of batteries ever?
No. When it goes, down, it will alert you, okay, you've got 15 minutes to go ahead and change your batteries with a yellow flashing battery. If you ever get to the red flashing battery, it means hurry up because, well, you've made a mistake. At the very beginning, I had a generation of batteries that lasted 3 to 4 hours. So you always carried batteries with you no matter where you were because you were going to be changing them. The current generation of batteries lasts right around 12 to 13 hours. So I can get up in the morning, I can switch into my batteries, and then throughout the day, I really don't have to think about it.
Explain at night. You hook
Yeah.
in, yeah.
At nighttime, I plug myself in. Basically, where the batteries come out, there are 2 leads that go into a machine. It's about the size of an Xbox. It kind of looks like an Xbox. And it does all the work of the battery because it's actually plugged into the power outlet. And you think, oh no, what happens if the electricity goes off? A very loud alarm. However, there is a backup battery within the device itself that allows you to switch over to the external batteries. And then when as I said, when it comes time in the morning, it's a matter of getting up and putting one battery in and then unhooking and putting the other battery in. You never want to do both off at once.
All right.
I've done that once.
No. Any advice for Dick Cheney?
Yeah, don't go swimming. And, I'm glad to hear that he is going back to an active life as well. I think that's part of it. It's a matter of psychologically, you've got to be prepared as well. You can sit at home and go, oh my goodness, it's all for me. Or you can go and live your life. And so I think that's really important. And while I've got the microphone, I'm going to take and I'm going to urge everyone, as Dr. Stempien-Otero spoke of, is the problem with transplantations is there's not enough hearts. There's no reason that should be the case. Talk to your family about transplant or organ donations. If you're qualified, consider it yourself. But make sure, even if you sign up a donor card, to make sure you talk to your family about that's what your desire is, because your family actually has the final word. So I just wanted to say that because there are enough people out in the world who unfortunately are dying, but those people can actually, give a gift of life.
Thanks, Rodney.
You're welcome.
So, Rodney's inspirational, but the reason I'm at the University of Washington is I want to figure out more and better ways. So is there another way? Is there something beyond the LVAD that we can do? And what I've been fascinated by is I've taken care of 3 or 4 patients here who've come in acutely ill and gotten LVADs, and their hearts have gotten better. So, and the LVAD has been explanted, and they live today without an LVAD with a better heart. And we call that a bridge to recovery. And it is using the LVAD to heal the heart instead of replacing it. There was a very fascinating study that was done in England where they take patients with heart failure without acute inflammation, and they put LVADs in them who were very ill. Then they put them on routine heart failure meds that they previously couldn't tolerate because of the degree of their heart failure, lisinopril, carvedilol, spironolactone. On these heart failure medicines, with the LVAD in, the size of their heart shrunk. Just like Dr. Poole showed with the BiV pacing, the heart became, from big and globular, it started to shrink. It didn't have to work as hard with the LVADs, and these medicines that we developed so long ago did their work. After that happened, they used a novel thing of clenbuterol, which is actually a drug that's used to dope horses in horse racing in this country, but is legal in England, to train the heart to work hard again. And in these patients, these 15 patients that underwent this protocol, 11 were able to have their LVADs explanted. This is a figure from the study, and each different colored line here represents a different patient, and this is looking at ejection fraction. So you can see before implantation, their ejection fractions were abysmal in the 10 to less than 20%. After implantation with the medical regimen, they all uniformly went up. These are all the ones that were able to be explanted. And even after explant, of the 11, 9 of them were still alive at 5 years post-explant. 1 went on to transplantation, 1 needed a biventricular pacemaker and had improvement from that. So what if we could use LVAD therapy to somehow reset heart failure in some patients? And what if the patients that could no longer get their hearts better from just medicines with an LVAD could undergo a more durable repair? So what could that durable repair be? Well, it could be new cells in the heart, because one of the major issues in heart failure is that you lose heart muscle cells, and those heart muscle cells are replaced by scar tissue. So you have scar tissue that doesn't contract and is actually very stiff, and you have a loss of heart muscle cells. In addition, in patients who have cardiomyopathy and heart failure due to ischemic heart disease, you have a loss of blood vessels, so you don't have a blood supply to the heart muscle cells. So people have been asking for the last 10 years, can cell therapy improve heart function? And there have been studies in Europe that have shown that injection of bone marrow, autologous from the own patient, into patients who have ischemic heart disease who are undergoing CABG leads to small improvements in their squeezing function and in their perfusion or blood vessels in the heart. But we don't know why this improvement occurs, and it's only a small improvement. So we've asked ourselves a lot of questions in animal models, what is the best cell? Why is this happening? We sometimes in animals show blood vessels growing, we sometimes don't, and it's very confusing once you get into a human that is different than a mouse as to what is the most effective cell type, what is it doing, how can we make this heal the heart? And we don't know if we could combine cells with LVAD therapy, because once patients get sick enough that they need an LVAD, potentially this would be a treatment. We could give them the LVAD, the cell therapy, and see if they recover from it. So we sat off as scientists to test a hypothesis, which is we asked ourselves the question, does direct injection of bone marrow-derived cells into ischemic human tissue increase blood vessel formation? And does it happen because stem cells in the bone marrow actually turn into blood vessel cells? Or does it happen because the non-stem cells talk to the other cells in the heart and improve regeneration? Or is it a combination of both? So to look at that kind of from a cartoon perspective, if you inject bone marrow into heart muscle in humans, do you get a cell that turns into a piece of a blood vessel and causes increased blood vessel formation? Or do you get a cell that takes the endogenous repair processes of the heart and activates them? And again, could this occur in patients with LVADs? So we took advantage of the fact that we see patients that need LVADs as a bridge to cardiac transplantation. And the LVAD, as you saw, is an open heart procedure. The heart is accessible, it's open, we have access to it. Many of these patients who undergo LVADs undergo a heart transplantation. At that point, they don't need that heart anymore. It's harvested, and we can take a look at it. So we have one point in time where the heart's accessible, and we could potentially take bone marrow before the LVAD, inject it into the heart at the time of the LVAD placement, and then harvest the tissue for transplant. And with that idea, a group of us wrote to the FDA and received an investigational new drug application to use bone marrow as cell therapy in patients undergoing LVAD placement here at the University of Washington. And what we do is we take bone marrow the day before the LVAD surgery, We take what we call the BMMC, or the bone marrow mononuclear cells. We kind of clean it all up. We get rid of the red cells and the little tiny pieces of bone that are left in it. And this is a mix of stem cells and non-stem cells. So some of the bone marrow cells are put aside. We then take the rest of them and we separate them into one fraction that has pure stem cells and one fraction that has no stem cells whatsoever. We also have a iron loading protocol so that we take these cells and they take up iron nanoparticles, which enables us to track the cells once they're injected. In the operating room, we inject 4 different things into the patient's hearts who are undergoing the LVAD placement. One of them is the whole marrow, or the bone marrow mononuclear cells. One is the stem cells. One is the no stem cells fraction. And then we have a saline control, because part of us thinks that maybe the European trials were just sticking a needle in the heart, stimulated something that improved function. So because this is a randomized trial, I do the bone marrow. The next day I get the fractions in vials that are just labeled 1 through 4. And we rotate where we put them in the heart every time. So I have no idea if vial 3 contains saline or stem cells or whatever. We just record it. And then, after we've injected them as part of that LVAD procedure that Dr. Mokadam does, sews them up, and we gather safety data. And this is required by the FDA for any type of investigational trial such as this. We look for bleeding or reoperation. One concern is if you're sticking needles in the heart, potentially you're going to cause increased bleeding from the procedure. Another big concern in cell therapy is if you are injecting cells into the heart, that you could actually cause the arrhythmias that Dr. Poole talked about. Those arrhythmias are set up by pieces of scar tissue and abnormal tissue. Are you causing an abnormal tissue to grow in the area of the cells? So we very carefully monitor bleeding and arrhythmias the first 7 days after the cell injection procedure. And then I'm required to meet with my safety monitor. We go over all the data. We analyze, could any of these procedures have caused these complications prior to enrolling the next patient. So after each patient, we say, yes, it was safe, we can go on to the next one. And then we're looking at late other effects long-term of arrhythmias and echo. So after we've done this procedure, we're all really excited, we've got the stem cells in the heart, and then we wait. And essentially, the patient is acting as an incubator for their own cells, and we're waiting for them to be transplanted. And so at the time of transplant, we then have access to the heart. And this is actually a heart of a patient who was injected with stem cells and explanted in November. You can see this is the LVAD right here, the pump going into the core. Here are some of Dr. Poole's handiwork. Those are the defibrillator and pacemaker wires going into the heart. They kind of cut them off right there. And these holes are where we cut out the tissue that we injected. We had marked it with little markers at the time, so we knew exactly where to go. And we could say, okay, this is the tissue we injected, and we're going to take a look and see what happened to those cells that we put in this human heart. When we take the cells out, we take a big square chunk like this, and we're looking at several different things. Most of the chunk goes to looking at microscopy, looking under a microscope for cells. We also take some tissue and freeze it away for analysis of genes to look for whether or not there's activity of certain things with stem cells versus non-stem cell fractions. And then we take the cells and we separate them into their components. So we separate out the cells that make inflammation in the heart and the cells that make collagen in the heart and the heart muscle cells, and we measure them individually to see how has a stem cell injection affected their function within the heart. And here is an actual subject who, this is the tissue. So all this dark pink is heart muscle. The light pink areas you see here are scar tissue. And this is a fairly classic of what we see in a patient with end-stage heart disease down here. Lots of scar tissue mixed up with the muscle. Here's a big blood vessel right here. So what we do is we can see here this thin line that goes from the outside of the heart in. And we believe that this is what we call a needle track from the injection of the cells. And our goal is then to take this area where the injection is and to measure the number of blood vessels that form in the area, the amount of scar tissue, inflammation, to determine if there's been an improvement with the cells. In addition, we want to know, are the cells even still there? What you're looking at is tissue that was harvested 6 months after we injected cells into this particular subject. So we took this area and we stained it for a particular stain that stains, called Prussian blue, that stains iron, so that the cells that are loaded with the iron nanoparticles will stain blue. So if we take that area and blow it up with the Prussian blue stain, what we see, remarkably, are multiple blue iron-laden cells within the area that we injected. So 6 months later, we have evidence that the cells that we injected are still in some point there. Now, this could be that they were eaten by neighboring cells, and at this point, we haven't analyzed these data fully. I mean, what I'm showing you, I'm presenting in 3 days in Colorado at a experimental therapeutics meeting. So this is pretty much cutting edge here. We've enrolled 4 of our planned 12 subjects, and once we get 4 completely harvested, we'll start analyzing the data. We've harvested 3 of them. We have an additional one that we just injected. We collected his marrow on Valentine's Day. I thought that was very appropriate. And what I can tell you is we actually haven't had excess bleeding or arrhythmias in the patients that we've injected to date in comparison with other patients who are getting LVADs. So the current status of cardiac stem cell therapy, people ask me this all the time. Well, what's the status? When are stem cells going to heal me, doc? I hear that in my office every week. And I can tell them that we are there and that we've developed a model in which we can inject autologous stem cells at least, so not embryonic or other ones, but at least ones that our own body makes into ischemic hearts at the time of LVAD placement. We can identify the sites, we can figure out what happened to these cells, and we can start to analyze this. And we believe that this is going to form a platform as we develop more sophisticated cell therapies that potentially could grow heart muscle back or heart blood vessels. It's a relatively rapid way within a human to figure out how is the human tissue going to react to these different cells in a very safe situation in which you have an LVAD completely taking over the heart's function, with a goal that eventually we could use these cells to heal the heart. So I just want to acknowledge from the research perspective that this type of study requires a lot of people. Nahush Mokadam is the surgeon that injects the cells. Chuck Murray at the Institute for Stem Cell and Regenerative Medicine has been very supportive. Jim Caldwell, the division head of cardiology, helps with it. And my funding, in addition to the NIH, your tax dollars, is through the Institute for Translational Health Sciences here at the university that promotes this type of research, which is really taking research from the bedside into humans and translating what we find out in the lab into humans. And then the Fred Hutch. I've been blessed that I had this idea to do this kind of research, and I ended up in a city where they have done more bone marrow translational research than any place in the world. And so they've been remarkably helpful. So what are the future directions for stem cell therapy? Well, we're completing enrollment. We're also developing in the cath lab ways of injecting cells so that we don't have to have open heart surgery to inject them. We can just go through the blood vessels and inject cells inside the heart. In addition, we're continuing our bench research to develop better cells. Can we develop cardiac muscle cells? Can we develop complete blood vessels? And my particular interest is how do we reduce the underlying scar tissue and inflammation so these muscle cells and blood vessels will take better and survive in the heart? And continue to bring this bench to bedside there to understand these effects. And then what we take in the patients, we go back to the bench and ask the question. So it's a double two-way street, bench to bedside, bedside to bench. Rhythm disorders. Where are we going, Jeannie?
Well, there's a lot coming down the pike, but before I tell you about that, I just want to thank you for listening tonight, and I hope if I've left you with anything regarding rhythm disorders, it's that I've raised your awareness of the problem of sudden cardiac arrest in this country. Because again, it's the number 3 reason to die And I always think of it as a tragic way to die because I showed you how easy it is to shock that rhythm. We do it all the time. Every time we implant a device, we put people into VF and we take them right out. It's a really simple thing. It's a matter of time. When 10 minutes, 15 minutes, 20 minutes goes by, that's the issue. Again, we're lucky to live in Seattle, but even there, the survival rates maybe approach 35, 40% at most if you don't have an implanted defibrillator. So knowing whether or not, if you have heart disease, you're eligible for a device and you don't have one, or if you have family members or friends that have had heart disease, it's important to know. So that ejection fraction, you got to know that. And it's a rhythm abnormality that affects people of all ages. We all know of the tragic stories of competitive athletes at young ages who have died from sudden cardiac arrest. So we need to raise awareness. So that's one of my passions in life, is to help raise awareness for this public health problem. So where are we going with devices? Well, there's some great innovations coming down the pike that I'm interested in. I'll be involved in making these devices safer. But one of the things that's on the frontier is devices that don't even require hardware inside the heart or minimal hardware inside the heart. The FDA likely will approve sometime in the next year a device that's a defibrillator that's completely placed just under the skin. So patients who don't need the pacing therapies, it would be an ideal type of device for that patient, particularly the young patients. So that's coming out. There's also pacemakers that will work through ultrasound rather than just dependent upon electricity. Again, minimizing the hardware that has to go inside the heart. Also, ablative techniques, which I didn't talk about tonight, but addressing heart rhythms with cautery. So we can put catheters up inside the heart, find the spots where the abnormal electrical impulses are coming from, and cauterize them. So advanced techniques using this cardiac ablation therapy. And there's gene therapy that's applicable to heart rhythm. Abnormalities. There's gene-based biological pacemakers that use viral vectors on mesenchymal cells, and it's been tested already in animal models. There are genetic modifications tested at the AV node that mimic the use of a beta blocker, so you don't even need a medication. That would be pretty cool. Other gene therapies that are looking at modification and expression of potassium and sodium channel genes, and these are the genes, channels on the cell membranes that are involved with abnormal electrical impulses. So there's a lot that's being learned at the cellular level. And finally, looking at the actual myocardial working cells, the sarcoplasmic reticulum, as well as the exchange pumps across the cells. All of this has to do with the electrical stability of the heart. So that's kind of the future for us. And I've been delighted to be a part of this over the last several decades, and being part of the University of Washington and living in Seattle, where we really have focused on saving lives and preventing sudden cardiac arrest. Oh, we'll just leave you with, as women in our field, we love our jobs, we love our patients, but guess what? We love our kids more. So thank you all for coming out tonight. We really appreciate it. And thank you to Mr. Garka for coming.
I think we'll open it up for questions for the docs. And would you take some questions? We maybe have you sit up here, and we'd like you to come to the microphones in the center aisles if you have questions. And we don't want to keep them too late, but I think this is fascinating. It is so cool, I can hardly stand this. It's just so totally cool. Over there, and speak into the microphone.
Yes, you mentioned thinking of LVAD and other treatments as destination therapy, whereas it used to be a heart transplant that was the destination therapy, now it's LVAD and the others. And I was going to ask, isn't there considerable merit in that, in the sense that if you don't have a heart transplant, you don't have to deal with a lifetime of immunosuppression, which from what I know, and maybe my knowledge isn't current, but what I know of immunosuppression, a lifetime of it, it's pretty bad, isn't it?
Yeah, it is. I mean, I look at a heart transplant as trading one disease for another. You're trading heart failure for immunosuppression. immunosuppression itself being, fraught with issues with getting infections and cancers. So certainly, our statistics for transplant here are excellent. 80% of people are alive at 10 years. We have patients who are 20 to 25 years out from transplant. But if we could potentially have a device that did that without having to have all the medications, yes, I think that would be ideal.
Yeah, and you mentioned the fact that immunosuppression greatly increases the risk of cancer too, and you're right. And I'm sorry, you're the doctor. I shouldn't be telling you you're right, but I think that's something that a lot of people don't know, that a lot of transplant patients ultimately die of cancer.
It's true.
Over here?
Yes, with the implanted device turning at 9,000 RPM, doesn't that damage the blood or tear the red blood cells to
Great
pieces?
question.
Yeah.
Yeah, so it actually does, and hemolysis or rupture of the red blood cells within the bloodstream can be a problem. Have you had any problems with hemolysis, Rodney?
I haven't had any problems. That is one of the things that each month with the blood work, they do check, and they want to make sure there's no signs of that. I've been fortunate, and that hasn't been an issue at all.
They actually have what are called stators at the inflow and outflow of the pump that stream the blood along the rotator to decrease that as much as possible. But certainly some patients do have that problem.
Thanks.
As our next person comes up the mic, I'm just going to ask a question since I'm one of the masters. Is there psychotherapy preparation for this? I mean, do you have counseling? Because that might just drive me crazy.
Yeah, prior to the LVAD placement, there was discussion. I was in the hospital. Honestly, at first, I was tentative. However, I also realized that it was necessary and probably offered the best chance. Following the, okay, let's go ahead and do this. As was discussed, the 24/7 assistance, those individuals who, are gonna be your buddies, they are brought in for training in that as well. That way they can understand what is going on. If an alarm goes off, what is meant by that alarm, and then what can be addressed. I think, anytime you have heart failure, you're also more, I think, aware of your own mortality. And anytime, frankly, this is all sort of still experimentation in a great sense. But you understand that, and hey, Dick Cheney's got one now. So, hey, anytime that I think there can be an advancement and you can be part of that, I think it's an opportunity that should be taken up.
Very cool. Over there?
Hi,
Yep.
I'm curious, actually it's kind of a two-part question, but based on the idea that no longer do you have a pulse when you have this, have you seen any interesting, any new realizations having to do with other tissues, other organs in the system relative to a pulse space versus a non-pulse space?
Yeah, so that's an interesting question. The thing that we have discovered is that the organ that most needs a pulse turns out to be your intestines. And so we've had the biggest complication besides infection with the non-pulsatile are gastrointestinal bleeds, that the small vessels in the intestines become very sensitive. And completely, how could you predict that one? It's just, there's no physiology that thinks it. But that is the major thing we've learned. But otherwise, the non-pulsatile state is remarkably stable. It's incredible. And yeah, as you point out, we can't take a blood pressure on him because there's no, high and low. There's just a mean, constant.
It is fun. It is fun if you know someone who's in nursing or a nursing student to say, yeah, you can go ahead and take the pulse. And, yeah.
The second part has to do with the variability of the heart. Normally, it goes up and down based on activity and things of that nature. Do you have a manual control, or how would you approach climbing a set of stairs as opposed to sitting on the couch?
It's constant. the blood is always flowing.
What happens is more blood gets delivered. So as you exercise and your adrenergic system starts delivering more blood from the right across the lungs to the left, then more blood volume goes. So it kind of automatically regulates. It uses your own body's system to increase cardiac output with exertion.
And blood vessels will contract and dilate
Yes,
accordingly.
independently, yeah.
Thank you.
Yep.
Instead of having a wire through
Step a little closer to the mic.
instead of having a wire through the abdominal wall, what prevents you from using induction to power this?
Yeah, so I mean, that's the next great thing is can you have some sort of induction battery? And there was a company that had developed that it was kind of thing where they had a bad device and a good battery, and this, you know, the company that succeeded has a better device. I think that we're all very nervous about the connection for the constant battery, and I think that it'll take until we have better implanted backup batteries. I think the defibrillator technology and development of batteries there is key because they're developing better and better batteries that could eventually be an internal backup for this so that you could have induction through the skin, but know that, you know, if you lost it for an hour, you'd be okay.
Well, let's thank them, the three of them. It's fascinating. Thank you.